not getting anyone through for the next question, that's fine. I'm actually going to just run through on the screen then. We can bypass the timers. I will put this up for a little bit though, so that you can actually see and have a read through. So this is the case here. Let's pop it up onto screen. I'll give you all a minute to have a read through. While you're reading this, I want you to have a think about how you would approach this case. Hopefully you've got a bit of paper in front of you at the moment, and I want you to write down on that what you would be writing up for this patient if this were the case for you today. All right, so hopefully you've had a bit of a chance to have a good read through there, have a think of how you'd approach this case. And this is a case that does have a hidden little twist to it. So essentially here we've got a middle-aged male presenting with chest pain, kind of intermittent chest pain, and a bit of uncertainty as to should he be here. He's a bit anxious, a bit flushed, but if you're reading through, I'm sure you're acknowledging this is a patient that has lots of little kind of red flags for having cardiac chest pain. But so far, pretty reassuring investigation results. What I want you to be focusing on here is, well, what is the additional bits of history that you would want to get for a patient in this condition? And the secret to this case is that this is a delivery driver, but he went to a party a few days ago and, wouldn't you know it, happened to have a little sneaky bit of cocaine. Once you get that bit of history there, this case changes completely. This goes from a chest pain with risk factors that probably need some outpatient follow-up through to this is a patient that actually does need a lot of workup going on. So first thing first is to acknowledge that finding, to acknowledge the severity of it. And if you are searching for brownie points, I want you to have noticed that this is a patient that also taking metoprolol. Now, for those that may not know, hopefully you guys here are aware of this. Metoprolol has the beta blockade activity, beta blocker. Yep, cool. Cocaine has alpha and beta activity, so it stimulates both alpha and beta. And if you block your beta activity, you actually get unopposed alpha activity. That means you actually worsen coronary vasospasm and are worsening this kind of ischemic picture in a heart such as this. And this can linger for days after taking cocaine. So this is a patient then that first thing we need to do is actually take him off the beta blockers and to do a more onerous, more rigorous cardiac workup compared to someone who's just out and about on the street presenting similarly. So this station is really having that nuance to getting the history, getting those fun little details, making sure all those little things that we're put in medical school to check, but we're still actually checking them and getting those last little bits of information from the patient that may not be in the STEM here. Applying that knowledge then to the patient context, taking into consideration all the information that has been provided and recognising the acuity of a patient situation and escalating as appropriate. Hopefully, the marking rubric for here was going to be recognising the importance of thorough history taking, including the recreational drug use, demonstrating the altered management approach with cocaine-related chest pain, and appropriate initial management and referral for further care. We wanted a little bit of drug and alcohol counselling there on the risks of cocaine use, and doing this in a way that's non-judgmental, supporting the patient and making sure that we can maintain things like honest disclosure, and also reinforcing, this isn't your standard, chest pain with a negative troponin that, you see what time point that was done, maybe do a repeat and then organise out patient follow-up. This is a patient that's coming into the hospital. And I should probably point out as well, for those that didn't also recognise, look at the setting here. This was set in a rural ED. So automatically we need to be thinking of a GP working in that well, so that we're in the hospital